I had one psychiatrist, which was I think the straw that broke the camel's back, said basically, look, just go home, vegetate and die, because there's nothing we can do for you. You just have to get on with it. You've got it, it can't be cured. So go and live your life out. That was hurtful, extremely hurtful, very unprofessional, I might add. It was then, that's about when I tried suicide. I put a gun to my head, but I didn't pull the trigger because of my dog. I was sitting outside on a bench, and when I put the gun up to my head, he just walked straight out and put his head on my knee, and that sort of dragged me out of it, I guess. Zuche knew that I was hurting, and he was always by my side. And I thank him for getting me through that period. He just seemed to know that if I was in a really bad state, he would just come and sit beside me so that my hand could just touch his head and I could just pat him. So the power of dogs is something I would never dispute.
Ladies and gentlemen, thanks for coming back in on time. It's my great pleasure now to introduce Dr. Meaghan O'Donnell. Dr. O'Donnell is the Director of Research at the Phoenix, Australia, Centre for Post-Traumatic Mental Health, and she is the Associate Professor in the Department of Psychiatry at the University of Melbourne. She has over 100 peer-reviewed publications in the area of post-traumatic mental health and has a keen interest in post-traumatic psychometry and early intervention following trauma exposure. She is President of the International Society of the Traumatic Stress Studies and was recently awarded the prestigious Experienced Researcher Humboldt Fellowship to foster the international collaborations. She is on the editorial board of the European Journal of Traumatic Stress Studies. Ladies and gentlemen, please welcome Dr. O'Donnell.
Thank you. Hello, and thanks for returning and being here on a Saturday. I really appreciate that you've made the effort to be here. I'm going to talk about early intervention, and I really wanted to take this opportunity to look at the literature to give us an idea where we're currently at, what we know, and then I'm going to present some ideas about future directions. Now we've shown this slide about, 4 or 5. It's a competition of how many times you can show the same slide in one conference. But it's a very important slide, and I think it's a useful one to just take a look at early intervention and the idea that we might be targeting different things within early intervention. If this is, just to orientate you to the slide, this is traumatic stress symptoms with high symptoms up here. This is time, and this is a 6-year period where we followed, in this case, injury patients. And we grouped people based on their PTSD symptoms over time. And so we have this chronic group here, and we might ask the question, what would we do, what does early intervention do for this group? And I would argue that perhaps early intervention, and sorry, this here is when the traumatic event occurred. Early intervention here might change the trajectory for this group, and so we see them over time sloping down. So instead of maintaining a chronic trajectory, maybe we can change that trajectory and drop it down. We have this group here that look to be, over time, coming back to baseline. So they are recovering over time, but it takes them 6 years to get there. And early intervention for this group might be able to speed up that trajectory so that they recover quickly. And then we have these two trajectories that Sandy identified yesterday, and they get worse over time. They start off looking okay, but they get worse over time. And maybe early intervention can stop them getting worse, so keep them here. And then we have our resilient group, or our people who don't respond with symptoms of PTSD or PTS. And that's the majority of people. I think it's really important. And in early intervention, we probably wouldn't do too much with them. So that's a useful way of thinking that early intervention might be different things for different people. I also want to orientate you to a nice way of thinking about early intervention. There's different ways that we can think about it. The Institute of Medicine has identified a continuum of care, which is very useful for us. So they've identified that if we're looking at prevention of the development of disorder, we could look at universal, selective and indicated interventions, and I'll go through each of those. And then once we're in treatment, there's standard treatments, and then we recognise that some disorders have a maintenance, and so we might look at rehabilitation in this area. But we'll be focusing on this end of the spectrum, this end of the continuum of care. So, universal interventions are those where the intervention is designed for everyone who's been exposed to a traumatic event. So in the case of disasters, everyone who's been exposed, whether or not they're going to go on to develop mental health problems, will get an intervention. Then we have selective interventions, and these are the interventions that target people who may have risk factors for developing disorder. So a nice example for this is when you identify that someone's got high cholesterol and you might give them a statin. So they're not showing symptoms at the moment, but you're giving an intervention to prevent them developing disorder. There's indicated interventions, and these are the ones where you're targeting people who are starting to develop symptoms. And then we have standard treatment. So when we deliver treatments early, just as people develop their disorders, this would fit into this category. So an early intervention, another way of thinking about early interventions is the level of intensity of the intervention. So here we have a universal intervention, and the intensity of the intervention at this point is pretty minimal. It's a very low dose intervention, and you reach quite a few people. So this is all the people being exposed to, in this case, trauma. When you get to the selective or indicated interventions, we could intervene with a low intensity intervention. So these are the group are starting to develop some symptoms. They're a smaller group than the universal group. We can look at some kind of low dose intervention. And then once we get people who have actually developed disorder, we can have a high dose intervention. So it's another way of thinking about early intervention. So I'm going to present some systematic reviews of the literature in this area. Systematic reviews are a really nice way, and meta-analysis are a nice way of synthesising the literature. They're very rigorous, and in that sense they comment, and the evaluation of the literature is looking at the quality of the trial itself and to what certainty can we draw conclusions about the results. And they also bring all the trials together. So they look at quality and then what are the general findings. So in terms of prevention, there's been two recent, oops, back. I get very excited with these little things. So in terms of the prevention literature, there's been a couple of really, really good systematic reviews, meta-analysis, published relatively recently. We haven't published too much in the early intervention standard treatment, so this is when people actually have disorder. So I will refer to the Roberts meta-analysis. There's been some more recent guidelines, systematic reviews developed with guidelines, and they're very similar findings, so I will speak to that. Okay, so what do we know about universal interventions? So the Fenoris meta-analysis we identified that collaborative care was probably the only intervention, universal intervention, that was showing any significant effects. So collaborative care is very interesting in that it looks at care management. It's a stepped approach, and it looks at care management. So this is very similar to Janet talking yesterday about the working rehabilitation models. And this is where you ask people about their biggest concerns at the moment, and then you have care managers who help address those concerns. And so what you're doing is lowering the individual stress levels, which help them deal with a traumatic event. So this is a universal application because it was published by Doug Zadzik's group, where they offered the intervention to everyone who was coming through trauma service in a major teaching hospital, so trauma, injury, trauma. So they had a captive audience and they could offer it to everyone. So everyone got care management, and those people who needed a higher dose interventions then got some kind of, because they were showing symptoms of PTSD, got pharmacological intervention and or CBT. And there's a number of trials, and they show that it has relatively good support for its efficacy, but the strength of the evidence was pretty low. So it works, but it's not very strong. But in terms of universal interventions, it's really the only thing that we have that shows an effect. Whether it can be translated after a disaster or after combat or after in other environments, it works in a hospital environment, whether it can be translated is a question. Other universal interventions were reviewed. They included battle mind training. So these are the ones that had pretty good quality trials: cognitive therapy, prolonged exposure therapy. So this is Barbara Rathbound's group, was doing some interesting early interventions there, psychoeducation. And the meta-analysis concluded that there was insufficient evidence to say that any of these were effective. And I must qualify that the outcome that they were looking at was PTSD. So they may have benefits for other things. So we know that Battle Mind has been useful for reducing alcohol consumption. But in terms of preventing PTSD or reducing PTSD severity, the level of the evidence did not support the use of these interventions. When we look at pharmacological interventions, it's slightly different actually. So these are Sira Brandy's trial, systematic review, identified 15 trials looking at all these different interventions, and most of them were either with hydrocortisone or with beta blockers. And what they found was that the hydrocortisol produced a pretty large effect. So this was giving people an anti-inflammatory almost immediately after a traumatic event. And so we can think about the mechanism, but it's probably to do with looking at cortisol levels. And so their recommendation that this was promising, we've still got a long way to go before we start giving people Voltaren as soon as they've had a traumatic event. But the mechanism is something that's very useful for us to explore and think about developing further trials to explore. So this is a good place to keep doing research in. So that's a universal. That's all we have in terms of universal interventions. When we look at selective interventions, it's even worse. So there's only one trial identified. Again, it's Doug Zadzik's groups in University of Washington. And they did, so selective interventions are those who just have risk factors, and we target intervention to those with risk factors but no symptoms. And again, in a hospital setting, people who experienced injury, they did an automated screening process just of the kind of information that is automatically collected on people's case files. And they used that as an automatic screen, and anyone who screened at risk, and it was really broad stuff. It was things like whether they went to ICU, whether they had a past mental health history, those kind of very broad brush screens. They were automatically selected. They came into this intervention, and then they got that a collaborative care intervention. And that showed they were able to reduce the symptoms. So there's some evidence here, albeit one trial, that suggests that this might be a useful way to go in terms of selected interventions. We have a bit more happening in the indicated areas, so people with early symptoms. There were 7 studies identified. They included cognitive behavioural therapy, prolonged exposure, cognitive therapy, bit of drug work and hypnotherapy. And really the only thing that came up as being having some evidence base or a higher quality of recommendation was that 4 to 5 sessions of cognitive behavioural therapy did reduce symptoms of PTS, but it didn't. So this is Richard's early trials in acute stress disorder. It didn't reduce the incidence of PTSD, but did reduce the incidence of acute stress disorder, but didn't really show much around anxiety and depression. But this is pretty much, there was insufficient evidence in the other areas, the other interventions that they looked, apart from this trauma-focused CBT. And then when we look at the early intervention, you're probably all aware of this. It's in all the guidelines that have been published, the Australian guidelines, the UK and guidelines and ISTSS guidelines. And that's that there's a trauma-focused CBT when delivered early to people with early post-traumatic stress disorder is probably the most effective way to go. And nothing else is really showing an evidence base that would support it being used. Now, I do want to clarify here that just because it's saying there's a low support in the evidence, it doesn't mean it doesn't work. It's just that we don't have enough data in terms of these really sophisticated meta-analyses to find a significant finding. So don't leave here by saying these things don't work. It's just that we don't have enough evidence when they're pulled together. And I guess to highlight that point here is that when I was doing a review of early intervention in depression, there was a meta-analysis and they had 147 trials. And when you look at the number of trials in our trauma meta-analyses, they're tiny relative to what's happening in depression. So it really speaks to we need a lot more energy in this area doing trials in early intervention, because only when we have a large body of evidence can we make conclusions that we have a high degree of certainty about. Now, in terms of future directions, I wanted to highlight that all this work in post-trauma mental health in terms of early intervention has really focused on post-traumatic stress disorder. And I will argue that we need to look beyond PTSD. I think that message has come across very clearly throughout the 2 days of this conference. And I think I'll be arguing that we need to have a transdiagnostic approach to early intervention. So this is a beautiful slide. Let me take you through it. And it really justifies my point, and it speaks to Richard's point that he made earlier about how we have to look beyond PTSD. So I know I'm talking to the converted, but let me just show you a picture that proves my point. So this is a latent profile analysis. And this is 3 months after a traumatic event. And what we did was we looked at the rates of different disorders that people had at 3 months, and they were new disorders. So they were disorders that had developed post the traumatic event. And what we did was with a latent profile analysis, it groups people who have similar profiles of disorders. And what we did was we found that at 3 months, there was this group here that's high in depression, kind of low in other anxiety disorders, high alcohol abuse, and then, or is that PTSD? I can't see. High alcohol abuse, and kind of middling PTSD and generalized anxiety disorder. So they separated out from the other groups. Then there was this group that was kind of high PTSD, high generalized anxiety disorder, high depression, but no alcohol, substance abuse, and no kind of other, not too many other anxiety disorders. And then there's this group here that just are low on everything but have substance abuse issues, alcohol abuse and dependence. So interestingly, so what we're seeing here, I guess the point is you don't see a profile that is PTSD only. That it just doesn't happen. You have this comorbidity, and sometimes you don't even have PTSD. You have alcohol abuse or like a substance, or the main problem is depression and alcohol, but you don't see PTSD by itself. So we have to think broadly, and I'm saying really, I know you guys know all this, but I'm saying to the research community, we have to look beyond PTSD, and we have to think about the complexity that we see. And interestingly, these patterns occurred again, and this is 7 years later or 6 years later. The patterns are very, very similar. It's just that you see a recruitment of other disorders into these patterns. So the complexity, the longer you move away from the traumatic event, the complexity of the comorbidity increases. So we need to be a bit more clever with our interventions. And the other thing that we need to consider, and this is a latent transition analysis. So what this analysis does is look at people changing those classes. So even though at 3 months and 6 years we got similar patterns in terms of people's diagnostic picture, they're not the same people at 3 months and 6 years, or in this case at 12 months and 6 years. So people move across classes. And what that means is that, people who might be primarily having a PTSD, GAD, depression look, well then they, by 12 months they've really moved into an alcohol class, alcohol depression class. And then there's a group that moves from there into back to PTSD. So what we're seeing is that people move around. Their diagnoses, even if it's the complexity of their diagnoses, changes across time. And we need to address that with our interventions. And I think this is where we're going with our research. So when I said to you, I think we need to look at a transdiagnostic approach, I just want to qualify what I mean by transdiagnostic treatments. And transdiagnostic treatments are those that target the psychological processes or the vulnerabilities that contribute to the development or the maintenance of the disorders. So we're not targeting a disorder, and we're not even targeting a group of disorders. We're targeting the mechanisms that underpin. So if I sound just like what Richard said earlier, he just took my thunder, but we're saying the same thing. I'm just saying it better. So when we think about transdiagnostic approaches, there's some interesting ways to consider transdiagnostic interventions. The most common one at this point is the common elements approach. And what happens with common elements approach is when you say, well, this works for depression, behavioural activation works for depression, so we'll take that module and we'll put it here. And when people are very anxious, we need to educate them about anxiety, so we'll take a bit of that. And then when people are avoiding stuff, we do in vivo exposure, so we'll take a bit. So we get things that we know we have an evidence base, and we put them together. And then you get this transdiagnostic approach. It works for people with anxiety or depression. But it's the combination of elements that have been brought together. When there's another transdiagnostic approach that's called a universally applied transdiagnostic approach. And this is where your approach actually works across different disorders or different classes of disorders. So let's say affective and anxiety disorders, you pull them together and you have a universal approach that targets them. So cognitive therapy is a great example of a universal approach, a universally applied transdiagnostic approach. So you're using the same process, you're targeting cognitions, that's the mechanism that you're targeting, but you would do different kind of cognitive therapy. You'd be targeting different cognitions with depression, you target different cognitions with anxiety, but you're still using the same approach. So that's a universally applied transdiagnostic approach. But more recently, and I think this is really exciting, is the transdiagnostic approaches that target mechanism. And I think this is where we're going to see changes. And Richard's example was a beautiful example by targeting neural networks that we know are impairing someone's recovery. That would be a nice example of a mechanistically driven transdiagnostic approach. So let's just look at what's happening in the early intervention literature in interventions that have taken a transdiagnostic approach. I think we could argue that psychological first aid as a universal intervention is a transdiagnostic approach. You can see what's involved in, I'm sure you're all aware of psychological first aid. It's often delivered immediately after a crisis event or after a disasters especially. It's increasingly being used for occupations exposed to high levels of critical incidents. And the nice thing about it is very consistent with these principles of safety, connectedness, efficacy and calmness. So the uptake of people using psychological first aid has been immense. So this is WHO's when the Ebola outbreak happened a couple of years ago. This is an example of some of the products they developed to support their workers use psychological first aid. But we have to recognise that it's consensus driven, and at this point there is no evidence base to support it. There have been 3 systematic reviews that have reviewed the evidence for psychological first aid, and all 3 of them have found no papers. I really want to publish a systematic review that has no data. That's a really great publication. One day I want to do that. So we have no data to support it. What we do know is it doesn't make people worse. So and because it's consensus driven, we think it's the best thing that we have at this point, recognising its limitation of not having any empirical support. In terms of transdiagnostic early interventions, I'm just aware of the time, I better finish up. So there are, at this point, 3 early interventions that are brief. They have been developed explicitly for healthcare workers, non-mental health workers to deliver them. And then because you're targeting people just with subsyndromal symptoms, and because they've been explicitly developed for non-mental health workers, they're very useful. And so they're brief in the sense that they're 4 to 5 sessions. So at the moment, there's Skills for Psychological Recovery, which was developed after Hurricane Katrina. At the moment, there's no data supporting its efficacy. Problem Management Plus is a really interesting one that was developed by WHO. Richard Bryant was involved in this, and it has a number of RCTs that support its use. It was particularly developed to look at mental health symptoms more broadly, not explicitly after trauma, but it has a good evidence base. And then there's INTERPAR, the International Program for Promoting Adjustment and Recovery. And this is the one that was an international collaboration that Phoenix led, where we brought people together because we identified we needed a brief intervention that could be used after trauma and disasters specifically. And what's useful about this is it's different from those other 2 ones in that we have an emotional processing task to help process the memories, because we know that a lot of people who are having those early symptoms, subsyndromal symptoms after disaster and trauma, often have intrusive memories, and we need to look at a way of processing those. And just some really early, so this is our phase 2 trial, and we had just 15 people, but we had significant reductions in post-traumatic stress and in distress, and also in problems in functioning. So you see functioning changes, which was really exciting. What is interesting in this is that the feasibility of training people to deliver. So these are Red Cross volunteers and community nurses, and we could train them to deliver it in an effective way. So that kind of feasibility was really important to see. And then in terms of early treatment, I'm going to jump ahead here. I know we started a bit late, but I won't take too much time. We've trialled a couple of early transdiagnostic interventions. We did a modular one, the kind of common elements approach, and we trialled it in an early intervention trial with 46 people, and what we found was that it delivered, so these are people with a range of disorders, and what we found was it decreased, the blue is the intervention group, PTSD symptoms decreased over time, depression decreased, and we saw it in disability, decreased as well. So that led us to continue our early, that was a very early trial, and we wanted to continue the work in transdiagnostic interventions. We could show from that early pilot that we could deliver it early and still get effective results. We did a telephone version of that RCT and it wasn't effective. So the delivery mode is very, very important to consider. And finally, this is a current trial that we're running at the moment where we're using a transdiagnostic approach developed by the Boston group headed by David Barlow. And I love this intervention because it's really targeting the mechanisms that we think underpin a lot of the affective and depressive disorders. It's also got an evidence base with substance use disorders, but looking at motion dysregulation, cognitive distortions, and emotional avoidance. It's really targeting negative affect and avoidance of negative affect, and so by targeting those mechanisms, we aim to see if it's useful from an early intervention. There's good evidence at the moment for more chronic disorders, but bringing it into an early intervention is the first time that we're doing that. And also, it hasn't been trialled in trauma. So what's interesting is that there's not a exposure component to it, not a memory exposure component. So it'll be interesting to see whether the intrusive memories change by not targeting them. But because we're targeting emotion regulation and emotional avoidance, and whether by targeting those mechanisms we'll get changes in intrusive memories is a question that we're asking. So, thank you for listening. I guess the key thing is in early intervention, the lack of evidence, the lack of research in this area is remarkable. And I do think that we have the ability here and the potential of changing people's symptoms trajectories by intervening early. And I think a transdiagnostic approach, a mechanistic approach is the way to do that. There's a lot of work for us to do. Thank you. Let's acknowledge mine.